So MRD is really the most important prognostic feature we have in ALL. That said, we use MRD in combination with the baseline genotype. So for example, if someone has high risk, baseline genomic features, those in combination will be used to just define a patient's risk. But you really need both the pre-treatment characteristics and the post-treatment characteristics, specifically MRD. There's a large meta-analysis, of course, that shows that, not surprisingly, patients who achieve MRD negativity have much better outcomes than those patients who are persistently MRD positive. So how do we actually use MRD therapeutically, or how do we use it to inform our treatment decisions? Well, obviously we have blinatumomab now approved for several years now for patients who have MRD positive B-cell ALL. So that would be the first step, is that patients who are MRD positive despite initial chemotherapy should always receive blinatumomab as consolidation. The question then, and that's controversial, is what do we do for patients who clear their MRD with blinatumomab? Do we need to send them to transplant, or can we just watch those patients and can they be cured? Most of the analyses suggest that there's no difference in survival between those patients who undergo subsequent transplant or not. So it's really an individualized decision, and that's where I would again rely on the baseline treatment characteristics to make that decision. MRD is important in multiple contexts. It helps to decide, for example, after a patient has had CAR T cells, specifically using the highly sensitive next generation sequencing assays. Patients who have any persistent disease after CAR T cell therapy universally relapse, and so those patients should be consolidated afterwards with an allogeneic stem cell transplant, versus it's very reasonable for a patient who's received CAR T cell therapy, who's MRD negative using a very sensitive assay, to just monitor them and not necessarily pursue transplant after the CAR T cells. And then MRD is very important in pH positive ALL, where we use it to decide on whether a patient would be transplanted or not. Patients who achieve good MRD response, either a complete molecular response for PCR for BCR-ABL after about 3 months, or now I would argue that the next generation sequencing MRD assay is probably superior to that. Patients who achieve MRD negativity by about 3 months, there's analyses to suggest that those patients do not require transplant in first remission, and so we really use MRD to decide on transplant decision making in pH positive ALL.